All right. Dr. Syed Hashmi is a professor and director of the Bioinformatics Core at the Pediatrics Research Center and the Department of Pediatrics at McGovern Medical School with UT Health Houston. I'm introducing his bio here based on his teaching principles and guidance, which I'm sure we'll get to see today in the session. Um, Dr. Hashmi's teaching style is heavily influenced by the same teacher who started him off on his pathway in high school, and there's two important things that he learned. Guiding principle: teach students and not just content. Often instructors forget what it means to be a student, and in their attempt to get the content across, they fail to consider different experiences, prior knowledge, and learning styles of their students. Although a class course can't be tailored for each student as a one-size-fits-all paradigm, doesn't help either. Therefore, he often explains concepts from different angles and accompanied by multiple examples, and to supplement that, always available for discussions. And if someone doesn't get it, try, and again, and being open to students and informing them on the first day that there's an open door policy that extends to trainee and faculty, and anyone who can regularly approach to discuss concepts and issues that might be related to research. He believes taking time to explain the concepts rather than just answer questions helps understand the issue and enables it to apply to the future. And definitely that will be a great interaction we'll have today with the topic on AI and community health, power, promise, and responsibility. So without further ado, I turn it over to you, Dr. Hashmi.
Thank you, Wes. Hopefully I can live up to all that you just said. So thanks for the introduction. Today I'll be talking about artificial intelligence and community health, things that the coalition actually deals with. About 6 months ago, there was another presentation in this forum, and the speakers, Drs. Nabil and Perkins, talked about the use of AI in healthcare systems, specifically in clinical and hospital settings. There was a discussion about the potential for biases, things to watch out for, and it was a really good talk for those of you who may have attended it. However, as this group, the coalition, the collective, knows all too well, healthcare is not just physicians treating patients. There's so many additional stakeholders, so many additional partners that are involved that make the system hum along smoothly. There's the whole public health infrastructure. I mean, not only in terms of the academic sector, but also the government, the local, regional, state, federal. There are healthcare organizations, community-based organizations. You've got corporate partners, payer insurance systems, social service organizations, and so many more. It takes a lot of folks, a lot of whom are present here today, to create and sustain healthy communities. And without the independent work and the cooperation of all of you guys, all these stakeholders, the whole system would be extremely limited. Unfortunately, limitations like those lead to health disparities, lead to a breakdown across social and economic strata, and just leads to a world of haves and have-nots. And it is within this reality that I want to talk about AI and community health. There are so many different lenses that we can look at this from, right? There's health equity, there's health access, workforce augmentation, introduction of new technology, and so on and so forth. It's easy to get lost in the weeds here. So my goal here today is not to discuss things at specific levels, but more so at a systems level. I'm sure there are individuals here online right now who are already using AI in some capacity, right? I mean, it could be using ChatGPT, Grammarly, or some other LLM to help them with their daily work, maybe write a paper or draft an email. Maybe some of you haven't incorporated AI more cohesively into the larger framework of whatever you do, whether it be academics, research, community practice, whatever it is. So at the end of the conversation today, end of my talk, I'll open it up to the floor, and I would love to hear what all of you are doing as well. You know, as a coalition, as a collective, we learn from each other. We uplift each other. I'm a firm believer in not reinventing the wheel. So if someone is already using the technology in new ways, in novel ways, and works and what they've learned, it would be great for all of us to hear about it and learn from it. Right? So as I start, let me just preface everything with one other fact. AI is a tool. As with any tool, the impact and utility depends on how it's being used. It's also dependent on the user, us, and the effectiveness of the tool can vary quite dramatically based on the purpose, the setting, location, so on and so forth. So even though it's a tool, I should add that it's an extremely powerful tool. AI can do things faster than we ever can. It's amazing at finding patterns, much better than we were or can be. It can suggest plans of actions that mirror expert opinions. However, everything that the AI does, it's learning and giving you output and generating information based on what we already know. That's how it's learning stuff from what we've done in the past. It's not independently powerful, at least not right now. And by that, I mean that it still lacks understanding, right? It looks for correlations, for relationships, right? So as we talk through this, just remember that AI is a tool. It's a powerful tool, but it's a tool nonetheless. And whether it's good or bad is wholly dependent on how we use it. So the use of AI has been increasing exponentially for the last few years, right? I mean, the first applications of AI were in the 60s and 70s, so that's more than 50 years ago. However, due to limitations in computing power, it didn't really grow much past a few applications. These were predominantly in large academic centers, such as Stanford, and often had a research or a discovery focus. But over the last decade or so, there have been lots of changes in computing power. And especially since 2020, it has grown exponentially. It's becoming more ubiquitous. There's application how we educate the workforce to how we diagnose patients in clinics in terms of reading images. There's a lot of patient monitoring that comes in now via smart devices. There's predictive analysis, risk assessments related to clinical outcomes, workflow automation that a lot of us use it as well in terms of using LLMs for our daily workflow, and so much more. We're using in the clinics. In the talk 6 months ago, they talked about how it's being used in the clinics, in surgical settings, in clinical documentation, and so on and so forth. So there's a lot of use of AI in healthcare now than it was, let's say, 5 years ago. But a lot of what you see here is in a clinical setting, right? It is in a hospital, clinical healthcare setting rather than a community. And even though the adoption of AI has been quite robust on the clinical side with medical technology, it has lagged a bit over on the community health side. A lot of the impetus for adoption on the healthcare side has been from a consumer perspective, whether it's a consumer in healthcare, such as a hospital or a clinic, or individuals like you and I as end users. So the innovation there is not driven just by the need, but also guided by the business side of AI in healthcare, right? It's the return of investment that hospitals are thinking about. It's a return on investments that companies are thinking about. If I create this device, can I market it? Can I sell it? Right? When we think about public health and community, it changes the perspective, right? It's not that it hasn't occurred in professional settings that we work in the public and community health setting, but the adoption has just been slower. It started slow and initially was used for risk predictions and predictive models in general. There was work done in Houston during the COVID pandemic where AI models analyzed clinical data, demographics, comorbidities, imaging data to predict COVID-19 severity, hospitalization, mortality risks. I was involved in the project where we looked at some new nanotechnology devices to see if AI can help us use a little bit of saliva to predict, to have prognostic predictions. But over time, it is coming up more in our community as well, in community health. It's increasingly being used. And it's being used to improve access for prevention, for outreach, for population level outcomes. In Camden, New Jersey, they have used AI to map hospital utilization by zip code. They identify high cost, high need individuals, and then develop care management plans and programs that target those clusters. LA County has performed homelessness and health risk mapping. NYC has done this for opioid overdose hotspot mapping. We here in Houston have also been involved in natural disaster management, mapping, resources that would be available in case a hurricane comes. There's been other work done with reducing asthma-related ER visits in targeted communities. The CDC's Social Vulnerability Index uses AI. There's diabetes risk management and mapping there's a lot of work that is coming up. And the purpose of these mapping algorithms is to shift from reactive care, which is on the clinical side, patient falls sick, they come in, we treat them, to a more proactive intervention aspect. Right? It helps us to allocate limited resources and hopefully reduce health disparities in the process. There've also been models that have incorporated social determinants of health screenings in ER outpatient settings, in ER settings or outpatient settings. And they have used these models to identify high-risk individuals or communities. And then they match them to food banks or transportation programs or utility assistance programs, legal aid services, you name it. So the resource allocation aspect of AI adoption has occurred, and it's coming on strong, right? And it's not just from our academic side or the clinical side. There are also institutions like healthcare institutions, insurance companies that are getting involved as well. Atrium Health in North Carolina used claims data, clinical data, community level deprivation data to have create automated electronic referrals to community organizations, and then follow it with like some closed loop tracking to see if the referrals are actually leading to completion. So from a community health perspective, we can definitely see that AI can be helpful. It can be helpful in health equity, decreasing disparity. It can be helpful in monitoring all these things. It can be helpful in public health planning and policy and matching the needs of our populations to community-based organizations that can actually help them. And the use of AI in the community is, as you can possibly see from all this, is quite different from how it is in the hospital setting. It's not about acute diagnosis. It's not about treatment. It's about prevention, outreach, cost reduction. It's about early interventions, right? And the drivers are different. From the hospital side, it's often the return on the investment. Ours is not so much the financial aspect of it, right? So this is the promise that I have in the title. There is a lot of promise for AI to be used. It's picking up on the community health aspect, but still lagging behind its adoption in the clinical side of things. And there are lots of reasons for why this adoption has been slower. First of all, it's a funding issue, right? I mentioned the business side of AI. Community health centers, community-based organizations, a lot of the folks that are here on the call right now, they're often working on tight budgets. They have limited capital for AI infrastructure. They have limited capital to, for vendors, for pilot projects, and so on and so forth. The return on the investment that I mentioned a minute ago in the community is prevention focused. It's often long-term as well. And it's sometimes harder to measure than direct dollars and cents, right? It's not just in revenue terms that we can think about it. The limited funding leads to limited IT support, and especially for smaller organizations, it becomes an issue. They're often lacking data scientists. They're lacking advanced analytic teams. Even if they're able to get a AI platform on, managing it and working with it becomes an issue because they need expert help, all right? Which again costs, personnel cost as well, right? Additionally, a lot of these smaller systems, smaller organizations, they work off data coming off of so many different resources and sources, right? They could be private, they could be public. A lot of the hospitals and all, when they do it, they just go in and mine their EMRs. Insurance companies, they go in and look at all their claims data. But a lot of the organizations that are part of the coalition and the collective, like we have here, are limited in that aspect. They're using someone else's data. They don't have their own data ecosystems. And when you're using these ecosystems that belong to other people, there are a myriad of different ways these can differ, right? These systems are not always interoperable. They do not necessarily talk to each other. Adds a little level of complexity there. You add to all of this how overstretched our community health workers are. They have to comply with complex data sharing agreements. There's governance and regulatory bodies they have to deal with. It's a workforce limitation. There are just not enough people out there. It's operationalizing AI in a community health setting has these real world barriers, right? And when you move away from all of us and go to the other aspect, the stakeholders, the communities that we actually work in, then often we work in marginalized communities as well. We're talking about the elderly, the undocumented, rural populations at times, where trust concerns cannot be ignored. So all of these, sometimes on their own, sometimes along with other factors, can explain a lot of delay that we have seen in AI adoption in community health compared to clinical medicine, which is where we, the Coalition for Connected Care, or the collective, that's where we can come in and help things along, right? So all of that obviously raises a question. How should all of you, the stakeholders in community health, promote and or facilitate adoption of AI? And if any of you are thinking this, like hearing me talk about, well, look, on the clinical side, we're doing all this community health, we're not. You could be asking like, okay, how can we do it? But I would actually ask you to maybe recommend tweaking that question a bit, right? The question should not be about implementation. It should be more so about the strategy. It's not about moving our mindset from a technology push. It's rather thinking about a problem, right? If we just think of AI as like, ooh, this new technology, this new tool we can use, then we end up with what is known as tech solutionism, right? We're finding problems that the tech can fit. It's vendor-driven adoption, shiny object syndrome, right? And that's not what we should be thinking about. Rather, the sub-question to the larger question should be from a community health perspective. Does AI improve outcomes? Does it improve access? Will it be helpful in improving equity and the efficiency tied to whatever our missions are? And if it does not, adoption may be premature, right? I mean, is there a problem that we as humans are limited in, so AI can come in and do better at it? Is there decision-making or workflow bottleneck that's preventing us from doing things at a larger capacity? And obviously, and something near and dear to my heart, is we have to be really careful about the inequities that are already present in the system. AI, as many of you are probably aware, can easily worsen these inequities. It learns from data out there, junk in, junk out, right? Faulty data, data with biases built in lead to biased algorithms. So we have to think about it from these perspectives, right? And if we answer yes to that primary question and feel that it's time for AI, there are problems that yes, AI can help on, then we should move on to the next question, which is what structural, cultural, financial, and governance changes are required for AI to succeed in community health. All right. In effect, what we're asking is, what must change in our system for AI to work, and to work responsibly, and to work sustainably? The reason for this is that we are at a stage with computing power that we now have and will continue to grow, right? The power of AI is there. What it can achieve is not the limiting factor. The real constraints within our environment, ecosystem, are incentives, infrastructure, workforce readiness, data governance, and trust, right? So what we have to think about is, how can we do it? If we do it the right way, it can prevent implementation failure. Do it the right way, it's more efficient, it prevents workforce resistance. Do it the right way, it can prevent harms to equity and make it sustainable. Because let's face it, AI is here, the genie's out of the bottle, right? It's here, it's going to get more and more ubiquitous. It's going to be part of our daily lives, even more than it is right now. So we have to think about, get it on the ground floor, think about how we can manage and design everything so that as we proceed through the whole process, it does what we want it to do, rather than us trying to fit ourselves to what AI can do. All right, so some of the questions that I have listed here are not new, right? And a lot of folks in this room probably deal with these on a regular basis. Any program that comes up, we have to think about these things. But now a lot of these questions, it has a little AI, technology, data-driven twist, right? And we have to think about these things as we proceed through the process, right? Are there grants out there? Are there fundings? And if we are doing it, how will it reward prevention processes that we are trying to do, right? We have systems in place. If you bring something in, can my system here at UT, will it talk to Harris Health or Harris County Public Health Department or the state, right? Who owns the data? Who owns the accountability? If something goes wrong, who's responsible, right? How do we monitor biases? Because biases will be there. You cannot avoid them. Who's involved in the processes? Who's involved in the designing of all of these things? Are the rank and file staff who are actually doing most of the work, are they there? Is it user-friendly? And finally, do we have leadership alignment at the end of the day? There are folks on top who are making these decisions, right? Whether it's at the academic side, the government side, the city, state, federal, or even within smaller organizations, the leadership there. So with that in mind, to summarize, a health community focus can be rephrased perhaps as the following. Will AI meaningfully improve equity and prevention outcomes? And are we willing to redesign workflows, incentives, and governance to support whatever AI systems we bring into play, right? If the answer to either of these is no, then adoption should pause. And there's nothing wrong with that. For us as a coalition, as a collective, as a community, we have to go back to our community missions. Why are we doing what we're doing? What are the goals? And for each of us, we need to go in to each of these missions to see if AI can uniquely advance any to all of those missions. And if it can, it's not just about adoption, but about enabling responsible adoption, which hopefully leads across all our partners. As the old saying goes, the road to hell is paved with good intentions, right? We in the healthcare system, especially in the clinical side, we have utilized technology and techniques that at first glance seem extremely promising, and there were, but unfortunately, it wasn't the same for everybody. They led to systemizing and institutionalizing disparities that already occurred and sometimes bringing up new ones. Inequities can get worse. So all of us, are at a crucial fork in time, right? AI is here, like I said, it's not going away. It's really powerful and it can be useful, right? But we can inadvertently start something that takes us 10 steps back with respect to health equity and disparities, which a lot of us focus on. And we have to be careful about that. And that's a responsibility part of this talk. So what I'm going to do now is this presents 5 possible steps that institutions and organizations can use, right? Obviously, this can be done at the collective level. It can be done at individual units within organizations, within CBOs, within universities, the School of Public Health, Harris County, whatever, right? First of all, we have to ask the question, is there alignment between that problem and the mission, right? The reason that all of us are here, on this talk, right, is that we're working together, right? The collective, the coalitions working together. We're cognizant of the fact that some of the problems cannot be solved by just a few of us or just one of us. A lot of the problems require effort, it requires partnership, it requires resources that necessitate collectives like we have here, right? And the overarching umbrella over all of this is how will we advance equity and advance our mission, right? So this part about the mission and what the problem is, they have to be aligned. Does the problem that we're talking about, whatever the problem may be, let's say it's access to certain resources by the community, right? We have to identify, does it significantly impact the health equity mission of our thing? And if it is, how complex is it? How large is this problem? Can we, as humans, just do it by ourselves, right? And if we go ahead and try to solve this using AI, would it really, really make a difference to our larger community mission, right? We should be mission driven, right? There's a lot of ways we can use AI, and I'm not saying that you shouldn't. But if you're looking at the larger big picture stuff, there has to be alignment with the mission. We have to solve something that helps us work towards a mission to, let's say, reduce inequity or provide resources or to educate the community or whatever the mission may be. All right. Once we have that done, obviously if the answer to any of those questions over there was a no, then we stop. We have to pause adoption. But if it's yes, we move on to step 2. Here, what we're trying to do is align our values and our incentives, right? So everything requires money. Unfortunately, it boils down to dollars and cents. So is there a financial pathway that makes it easy? If there's no funding model, or there's only limited funding model, then what are we trying to achieve here? We get some pilot funding, we do something, and we help a few folks, and then the funding goes away, and then we're like, sorry, we don't have anything left. You're on your own again. But it happens, and unfortunately, it happens for a lot of us. Funding is difficult to obtain, right? So, but if there is some kind of sustainable reimbursement, there's a savings model, whether that requires federal help like Medicare, all these kind of things, or there are private donors, whatever, that helps. So just doing it for like a year, 6 months, 2-year period is a bit of a disservice. Not that we should not do it. We should do it to see if it works and all, by all means. But we have to think about long-term planning as well. The other thing we have to think about is who benefits financially from the success of whatever we're doing, the AI infrastructure. We are community-based. We are community-focused. The organization should benefit. So like here at UT, we obviously think about the organization. We're not immune to that as well. But at the same time, there should be community benefit, right? Which is quite different from industry, where at times it is shareholders and so on and so forth, where the external payer assures that it has the main benefit. Finally, in terms of the value, we have to think about the return on investment that we have. What metrics do we have? Is this something that can be measured? Because as we go forward, I'll talk about how that's extremely important in doing audits and to make sure biases do not creep in, right? And these ROIs should be something that are manageable within our lifetimes. I mean, within our lifetimes in the sense that within 1, 2, 3 years, right? I mean, we're not like, I mean, of course, there are things that we can do and we should do that have long-term impacts as well. But we should also try to see where we can get, the most bang for the buck in the quickest time. Once we have those things, we have to move into infrastructure, right? Infrastructure cannot be weak, right? If one of us, let's say Harris County Public Health, creates a new data access tool or creates a new AI model algorithm, it spits out data, it creates a dashboard. How easily can all of us use it? How easily can the public health researchers at the School of Public Health use it? How easily can the community organizations that use that data to target populations and define their own objectives, how easily can they use it? We have a lot of fragmented systems currently in place, right? There's partial integration, but we're still fragmented. And it's always been the case. When EHR was first coming up, I was like, yes, good. But the way it was implemented was like, there were a few companies that came up. Everybody was doing their own thing. It was all proprietary, so no one could talk about it. And it just made things even more difficult to work with, right? The other thing is with infrastructure is like, do we have the capacity to do not only store the data, but to run analytics? Institutions like mine, UT, we're large and we have funds and that can do that. But smaller organizations may not be able to do that. Sometimes your vendors, the AI models that you pick, they have their own cloud computing, they have their analytics, but they may not, right? So if we have trusted academic medical centers as partners for a lot of these smaller organizations, that helps, right? You can decide whether you want to do it in-house or work in a larger picture. And finally, we have to audit model performance and bias. What I mean by that is we have to go back and see whatever AI algorithm we create, whatever AI is being used in the system, is it doing what it's intended to do? Is it accurate? Is it effective? Right? And to do that, we have to collect data. To check biases, we probably have some ideas about biases in creep and like, okay, or is it going to result in some gender differences or racial differences or so on and so forth, right? Whether a community gets it, doesn't, whether it's by socioeconomic strata. There are biases that we can think of and we have to collect data on those. But there are also other biases that we may not be aware of that will only come to light once it's been implemented. So we have to be able, whatever system we come in, with lots of different programs that all of you work in, they're not static. We are always working in a changing environment, right? often changes that are brought upon us, not within ourselves, but from external um, partners, for example, changes at the federal level. So we have to audit performance. We have to do bias checks because we have to make sure that whatever it's doing, the infrastructure is there and the data is good, that we can use it for whatever purposes we have in mind. Once we have all that infrastructure in place, next comes the workflows. As with any other system, any other program that any of you guys work with, buy-in from the workforce is critical. If the workforce perceives AI as surveillance or as a burden, adoption will fail. If the processes put in place are burdensome, if they increase workload, if they increase red tape associated with training and or certification, regardless of whether it's accompanied by increased compensation to all these individuals, adoption will still fail, right? We have to make it so that the folks who are rank and file, who are actually doing the work, who are actually using these resources, they can do it with ease. They have support. We've created systems that have interfaces that they like and that work with them. They need to be at the table when everything is being designed. And this goes not just to our workflows here, but also to the community aspect, right? We have to have community feedback as well. It has to be co-designed. As with a lot of, well-designed programs, you don't sit in your own little cocoon and design something, right? You don't talk to and at people, you talk with people. So it's important that AI, whatever we're doing, since it can do so much, it reduces our workload. Otherwise, what's the point of bringing it in, right? Why spend more money, create more systems, create more headaches, things that potentially can break down when we can do just as well and perhaps faster, right? Doesn't make sense. So this part is important. And finally, we have to have that equity and trust, right? The question is not just, when I was talking about the bias part a minute ago, is does AI work? I mean, which is what I was talking about. Is it doing what it's meant to do? Is it accurate enough? However, we should also add, does the AI strengthen trust? Does it protect vulnerable populations? Does it reduce rather than reinforce inequity? And to build a trustworthy and equitable system, there are 5 main safeguards that we have to keep in place, and most of you are going to be aware of these things, right? Number 1 is bias prevention and monitoring, right? I talked about it a bit already. If the model, whatever model we create, program disadvantages a subgroup, do we know it? And if it is doing so, can we fix it, which is even more important, right? So bias prevention and monitoring is key. Second, transparency, explainability, right? Often with a lot of AI, it becomes a proprietary issue. It's a black box. Oh, we created this model. It does stuff. You don't need to know. Trust me, it does stuff. But to build trust, we have to be open. What factors influence the prediction? And here's how we use it. It has to be open, right? That doesn't mean that, oh, I'm creating IP and I should not make benefit, and institutions, including ours, do care about those things. But at the same time, there is a lot to be said with open mechanisms in place, all right? Third, again, I touched upon it briefly, community governance and voice. Not from perhaps us, our group, but from in general, those are often overlooked from the healthcare perspective, the end users. We need community advisory boards. We need all the stakeholders involved. And the mechanisms have to be built into the system for feedback after deployment of whatever program or AI that you're doing. Fourth would be data dignity and privacy protection. Like I said, we're working with a lot of marginalized communities. Could this tool inadvertently create fear, create harm? Right? Perception matters as much as reality. Doesn't matter if it's actually doing it. Do they feel fear? Right? And we have to be careful about that. What privacy protections are in place? How closely can we deal with them? What legal parameters play into those as well? What are we supposed to do? What can we not do? What laws come into play? Fifth, accountability and escalation. Or I should say escalation pathways. Every AI team system or program should have some named executive sponsor, some governance body, and it should have a documented response plan. This should not be an afterthought. Oops, something went wrong. What should we do? This needs to be thought of at the get-go. You need to know that if something goes wrong, and trust me, something will go wrong, who's going to act? And how are they going to act? We have to build it into place from the get-go rather than be reactionary to that. So what's the role of us, the collective, right? The coalition. With the collective, we have a lot of power working together. Equity standards become shared. Infrastructure costs can be distributed. The data we collect from different resources and sources can improve model accuracy when it's training. Adoption can become coordinated, where the hospital and the public health professionals and the county and the CBOs are all working together. And then the bottom of all of this, or maybe the top of all of this, there's a community voice, which is institutionalized in the whole process. All right. So the collective, what we can do as AI is here, like I said, AI is here. And it's tech that can really help in a lot of different ways. And we have to think about implementation. But for us, with all these different bodies involved at the academic, state, city, and private and public levels, it's a cross-sector coordination problem, right? And we have to think about, are we, through the use of AI, improving equity at a population level, or just within our little scope? All right. So I mentioned a lot of these things. If we are going ahead with the collective and starting to create these things, we have to have some kind of shared infrastructure. All right. We, as a group, have to talk about this collectively. A lot of you might be doing things on your own as well. Maybe there are some pockets within the group that are doing it as well, but it needs to be vocal. It needs to be transparent. Everybody has to be involved in this. There has to be a governance hub for equity. There has to be protocols in place for data integration. And their decisions that are made have to be collaborative. You know, just the county or just the university cannot be sitting there going like, okay, this is how we're going to run things, right? Because not only are we sharing costs and resources, we are also sharing risk. And risks of all kinds, risks of doing wrong, risks, financial risks, legal risks, everything, whatever risk you can think of. We're sharing those as well. And through all of these things, we cannot forget our advocates, our advocacy professionals that are in the group as well. We need to be involved in policy as to how these things are being used. It's not much use of us creating a system and then, you know, folks at the city or the state level or even the federal level create laws that totally throw everything that we're doing to the side, or throwing wrenches to the whole plan where system will work, but now it's got issues with it. It doesn't work the way we want it to. All right, because that aspect, everything that we do in all of these things has to end up with whatever we're doing. Our work has to be a community trust amplifier. What we do today should result in the community trusting us so that we can do even more tomorrow. It's not an easy task, right? And we work a lot towards this thing, building that trust thing. But hours and days and weeks and months building trust can easily go away if the community finds out that the data that they gave us has now been given up to, I don't know, Meta, Facebook, or Google, so that they can create their own stuff. All right, so we have to be careful about these things. So this is an operational model that I've come up with, right? I mean, and as far as operational models go, it's not that different than what you would see in most programs, right? It's the same thing, just with an AI flavor. So on the top, there will be some kind of steering council, right? It involves academic partners, our healthcare partners, our government partners, our social partners, the community partners, right? These folks, these individuals will prioritize our use cases. They will approve the policies. They will ensure that the alignment is there as far as health equity is concerned. And once we go up past those, we have working groups, right? There'll be the technical AI and data part, right? A lot of academic aspect, you know, it's the building of these models, it's the data analyzing, it's the auditing, it's making sure that's working for everybody, it's the sharing. Academia said that it can be led by academics because we have resources that can do that. We can house a lot of data. We have resources to do these things. So house them and share them so that the other stakeholders don't have to spend all their votes on those. There's equity governance, right? We have to always keep that in mind, right? What are the ethics? What are the bias? Accountability. We cannot ignore the ethics aspect of it. A lot of times we talk about these things, and this whole talk came up because I was talking to Dr. McPherson about ethics after that last talk. We cannot ignore that aspect. Then there can be a workforce capacity issue. What training is required? How's the workflow design done? How will we incorporate it and adopt it? What changes will have to be in place? But finally, policy and sustainability. We have to find funding. And I'm talking about sustainability not just in terms of like money, but I'm sure all of you have heard that AI is resource intensive in terms of electricity, in terms of water, and all these kind of things. So we have to be smart about these things. Like, if we're doing this, why are we doing this? And is it sustainable? Not just sustainable for the program itself, but sustainable for the community, our city, our nation, the world, so on and so forth. And with all of this structure in place, we need to have that community advisory panel that I was talking about, right? The patients, the community health workers, the advocates, the local leaders, they need to be there. They have to review everything. There has to be transparency, because we have to have that trusting that I was talking about. So, final thoughts. If you choose to lead with purpose, if you choose to lead with governance, with partnership, AI is more than just the tool that I was talking about. It's more than just an innovative tool. It can become a catalyst. It can accelerate prevention. It can strengthen our trusts. It can direct resources where they're needed most. And collaboration through academic institutions, healthcare systems, government agency, community partners, we really have this rare opportunity right now to shape AI intentionally, not reactively. We can ensure that AI that comes out in the future reflects our values. We ensure that it advances equity in our communities. We ensure that it serves people and not the other way around. I mean, the question is no longer whether AI will shape community health. It will. The question is whether we will shape AI to reflect our commitment to health justice, to access, to dignity. And if we do this together, thoughtfully, in a transparent manner, and perhaps boldly, we won't just adopt this technology, right? We will end up building a more equitable health system, which is the goal that all of us have. So with that, I'll end, and thank you for your attention, and I'll open it up to the floor for questions and comments. And I'd love to hear how folks are using AI as well.
Well, thank you. There's been a lot of discussion while you're chatting, certainly about ways people use it and some of the ethical issues that come up. I know that there were two clarifying questions in the chat that I guess I could start with. I can ask them, or if
Sure, go
those
ahead,
who
if
asked
you
want
know what
to.
the questions are.
Yeah, Kara, let me find yours. Uh, one moment. Do you want to ask it, Kara? Or do you want me
Sure,
to?
and you can go back to the slide where there's like about the level of keep going adoption. I think it's step 1.
This one?
Yeah. So is your information a little backwards? So low
Sorry?
readiness is a no-go if there's marginal impact and
Oh,
strong.
sorry. What I was talking about was, for example, does the problem significantly impact health equity or access? When I'm
In a
talking about this, I'm
positive way?
talking from the AI perspective. Like when AI comes in,
Right.
will we significantly impact bringing AI into the system to solve a problem? Will it impact health equity or access? If it's not really making much of a change, why bring it in?
Okay, so what
All
we're
right. So
saying
this
is
is
that
like
making
yes, all of these things are like
positive
how
changes.
exactly,
Positive.
exactly,
Okay. I'm
exactly.
like,
Not that like, hey, it's a marginal impact, we shouldn't do anything. No, no, no. We should do it whatever we can. What I'm saying is like, should we actually bring AI in with all the issues, all the biases, all the equity concerns, everything else, if we're going to get a very small impact, right? So we have to consider, I'm not saying we should not be, but we have to consider whether it's the best use of our extremely, extremely limited resources.
right. I
That
think
was
I was
clear,
just,
Tara.
yeah, it's Kara. I think I was just confused on what major
Yes, sorry, I
barriers
should have been clearer
affecting
there. Yes,
vulnerable
this is from
populations
the AI
meant.
perspective.
Is it is it in a positive way or negative way? That's the
Yes.
thing that I was thinking. So I was thinking, well, if it's net, anyway, I got
Yes.
you. Thank
Thank
you.
you for bringing that up. Should have been clearer.
Okay, I know there's a hand raised, but before that, I'll ask the other clarifying from Sebas. I don't know if it's Sebastian or Sebastian Certuche. How do you address the black box issue if it's not even fully understood by the companies that create the is it LLMs or limits?
That is quite a concern. When I think about AI, especially when tools come out, right, and vendors come up, and I get emails all the time like, hey, maybe you can use this. Our system, obviously you purchase it for thousands of dollars and implement it in your clinics or our hospitals or our systems. My question is like, okay, what is it doing? Even the AIs that we use, like, I'm sure a lot of you are using LLMs, but then the question becomes, what data is it learning off of, right? What is it really mining? Is it mining things in an equitable fashion? Is it getting the right resources? We have in the past, using limited data sets, because our research, as everybody here is probably well aware, has predominantly been focused in certain groups. We have done whatever we find from these groups to everybody, right? We do it all the time. Just yesterday, I was talking to some students and they were looking at race. And I'm like, why are you getting race? Okay. And they're like, okay, we'll get like white, black, Asian. I'm like, and what is Asian going to tell you? It's not a monolithic group. I mean, why are you doing these things? And people just do these things and put it all together. The algorithms are there, and this is how it works. We really need to do that. A lot of companies, unfortunately, are not going to do that because of proprietary reasons. All right. And I wish I had an easy answer for you in terms of, well, we can easily solve it by doing this. But unfortunately, it's harder. Now, if we take the onus of creating these models, these algorithms, we can make it open. We can make it transparent. Rather than let others come up to us and say, like, this is how the AI works, or this is what the AI can do, use it. We should be like, these are our problems. We want to create an AI that solves this problem, keeping all these mission and goals and objectives in mind. So that's the power that we, as the coalition and the collective, have. We really have it. I mean, we can be reactive to these things or proactive and create a system that goes ahead and does it. So going back to your question, Sebastian, about the black box, it is an issue. I'm not going to, mask over that fact. It is a big, big issue. And even in academic centers, it is a big issue. But we have to consciously make an effort to be transparent and open. It has to be a driving principle. There's no other way around it.
All right, and I see the name personal with your hand raised. Do you want to go ahead and ask your?
Yes, thank you. So my name is Juan Arias. I was hearing to what you were saying a little bit ago about the black box, and I share your opinion in which the importance is not to use the tools that have been developed and try to understand how is that they work, but more likely develop models from scratch. So, and the experience that I have from that is based on diabetes, and with a group of folks, we were able to do that and try to turn all the complex feedbacks and things that are happening within an algorithm into one image that explains what's going on and what are the weights of the elements that build the model, to try to see which is the most meaningful things that may turn a person into becoming a diabetic. And basically, it's just a wristband based on a financial scoring system. It's just, and that's what made this, it turned from a black box model to a white box one. And then the other part, which is important, is that there are guidelines for you to show the transparency on this. And basically, that's a tripod AI guidelines. So if you're able to follow all that, you're able to show what you're doing, and you can turn that into a simple image that explains the model, then you got it. But that's going to be something that you use to solve a specific problem. It's not you using the ChatGPT or something, because Nobody knows how that works really. But you know how you build your model and you know how to explain what's going on. I think that's a key part.
I agree with both your comments, and that's totally correct. And that goes back to what I was talking about, where we have to be intentional about this, right? I mean, it's here. It will be used. And there are lots of systems out there that are using these in the universities and other academic centers and other partners that are making it open. And there are guidelines out there. There are groups that have published guidelines on how to make it as white box as possible and make it transparent as possible. And there's obviously the resource part that you talked about. It's expensive. I agree with you. But then over here at the School of Biomedical Informatics, McWilliams School of Biomedical Informatics here at the UT, we have teams that do a lot of work, and I work with a bunch of them, Dr. Jacques and Jung's whole team. They do a lot of work, and they can work with partners, and they can help create it from scratch. It all boils down to will and desire. And what will we decide to do? And what do we want to take control of? As opposed to just be reactionary and like, okay, someone's created, now I will use it. Nothing wrong with that. But you can be at the forefront and be the innovator there. So thank you for that comment. I totally agree with what you were saying.
And then
No.
Tara Robinson said that diversity is built from different lenses, so making sure AI is built from a foundation of diverse partnerships. Would you agree or disagree?
I 110% agree with that one. That coalition I was talking about, that community I was talking about. Community means everybody that's out there, not just like the government folks and the academic folks and the community folks. I'm talking about people in all flavors and shades and whatever you want to call it. It has to be all of us, right? Because the overarching principle of health equity, to decrease disparities, to work towards the common good, it's not something that can be done by just one group. It has to. So I totally agree with you. Thank you for bringing that up. It's that framework that I was talking about. We have to be intentional about these things. And it keeps coming back. All these comments, I keep coming back to this. We have this opportunity to become intentional. And I'm unsure, maybe Dr. McPherson can educate us on this one, but maybe the coalition can spearhead something. The partners are there. I'm sure folks are interested in these things. So let's design it to help not just us in Houston, but across the world.
Okay, see, Kara, you have your hand raised again.
Yeah, thank you. I'm gonna lower my hand. This looks very, the structure that you showed on with the image and all the structures looks very familiar to what people are talking about around health data utilities.
Yes.
And so I'm glad, yeah. One of my questions was, are you familiar with those? And it looks like you are.
Yes.
And do you think the AI focus should be first, or does a health data utility and that focus help
Sure.
support an AI implementation like this?
So first of all, yes, I'm aware of that. And this came off of that to an extent. But then again, it's not just the data part. There are other programs. I mean, this is nothing novel, right? And I should also add that this includes my biases and tunnel vision as well, right? There are probably things that a lot of you folks can add to it, and rightfully so. So this is by no means what everybody should. Please don't be like, okay, this is what we're doing. No, please improve on this. In fact, I recommend and highly promote improvement of this. But to answer your question about whether it should be the AI data part, I'm saying neither. I'm going back to our mission of health equity. I'm going back to our mission of decreasing disparities. That should be the focus. And everything else comes off of that. When we think about data and how we're managing it and how we're using it and how we're collecting it, we should have that in mind. Like the speaker just mentioned about, having everybody on the table, decreasing biases and all that. When we're talking about AI being used, how is it being used? Who is it being used by? Who is it being used for? All of these things have to have that lens of equity on top of it. So personally, and there might be folks in the group that might feel differently, and there's no right or wrong answer to this, I believe. But my personal opinion is that the health equity lens is what should color everything that we do. And when we come down from there, then it should be a data thing, going down to that second question you had, before we talk about the implementation thing, right? So at least that's my opinion. And again, not set in stone, right? I'm open to other thoughts, ideas. I'm more than happy to rethink things because, like I said, it does have my biases and tunnel vision. And I work in health equity, so I will obviously look at it from that lens first.
Thank you. I know, Heidi, you got your hand raised. Maybe we keep the chat open, but I know it's the end of the hour, so just want to thank everyone for coming, and I guess and let you all know that we'll put the recording up. Dr. Hashmi, can we get a copy of your slides to send out to the coalition?
Sure.
Okay,
More than
great.
happy. I'll send them to you.
Okay, so we'll send that out through the roster as well so that you have it. So
Yes, and if anybody has other questions, feel free to email me. What I'll do is I'll put my email address in the chat box.
great, and I'll also make sure to put your email in the follow-up email as well to the roster too, so that it's there. Okay, well, thank you
Thank you
everyone.
so much.
And thank you, Dr. Hashmi, again. That was great. And just so you know, Sean Haley said, when is part two? So, yep.
Well, part two should be okay. When are we getting together and starting work on this, right? So, yes. Also, Wesley, I don't know. I didn't read all the comments and the questions. Could you
Do you want me
safely
to export
chat?
a copy so you have it?
Yes, and just send it to
Yes,
me as well, please. Thank you.
absolutely. Okay, well,
But if
how about
anybody's
this?
interested in these things and wants to take the talk further and discussion further, please, I'm more than happy to. I mean, and I'm not the only one. We're like-minded folks here. There's a lot we can do. We really have a power in the collective, and that's my whole thing. We should use that power. All right.
Okay,
Thank you,
great.
everybody.
Well, thank you, everyone.
Thanks, Wesley.
Thank you. Thank you.